Excellent. Well, thank you so much for joining us. I think in the interest of time and in getting started here, we'll go ahead and move the program forward. So welcome everyone again. Thank you so much for joining us for Improving Lives by Detecting Sexually Transmitted Infections Early, which is part of our Value of Diagnostics within Women's Health series. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, which is the thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. We are pleased to have three distinguished panelists joining us for this public forum today. Fred Wyan, Director of Communications at the American Sexual Health Association, Dr. Claire Bristow, epidemiologist and assistant professor of medicine at the University of California, San Diego, and Dr. June Gibson, president and CEO of My Brother's Keeper, Inc. I'd also like to thank the sponsor of today's event, Roche. And as always, we will be live tweeting during the event, and we invite you to join us and use the hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Sexual Health on social media. And at this time, I would like to introduce SWHR's Chief Science Officer, Dr. Irene Aninye, who will be moderating today's forum.
Good afternoon. Thank you, Katie, and welcome everyone. Spanning from simple blood tests to X-rays and invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to very valuable information to help women make informed decisions about their health care across every stage of their lives. SWHR's Value of Diagnostics within Women's Health series highlights the importance of advances in screening and diagnostic technologies and approaches throughout the lifespan, with a focus on how we can improve health outcomes for women, particularly relating to female cancers, reproductive health, and bone health. Today's forum is in recognition of April being STI Awareness Month. Diagnostic testing for sexually transmitted infections involves simple and highly effective methods of identifying disease in sexually active individuals. Testing can be done quickly and easily, typically through a swab, urine, or blood sample, depending on the type of STI being screened. It is particularly important to be tested regularly since STIs may not have symptoms and can cause long-term health issues if left untreated. Incorporating regular STI testing throughout a woman's life makes it possible to diagnose and treat infections in the early stages. We'll begin our program today with Fred Wyan, who will share more about STI incidents and impacts on women's health across the lifespan. Thanks for joining us, Fred.
Well, thank you for having me. Okay, I hope you can see my slides. All right, well, thank you again for having me join you today. So a little bit about our organization. We are 108 years old, and we have a very broad sexual health mission, but essential to our identity over the last century plus has been working in what was venereal diseases, then sexually transmitted diseases. Now we refer to them as sexually transmitted infections. And so I've spent a lot of time in my communications work. I am the director of communications. That's really where I spend a lot of my effort is around the messaging and how to make them the most effective. And of course, this is an appropriate time, as was mentioned. This is STI Awareness Month. This is actually STI Awareness Week, too. The CDC is pushing out. So we're very busy. And I think the case is pretty clear as to why this work is needed. There you go. So on the top line, this is data on reportable STIs. These are cases that are reported to CDC from 2019 in women. And they're really staggering when you look at them. And chlamydia alone, well over 1 million cases. And also, when you look at the next line, these are some other common STIs that we talk about a lot. Look at trichomoniasis, over 3.5 million cases. So it's clear that these numbers are trending up, and they've been that way for a while. And this slide does not even capture HPV, the human papillomavirus. CDC believes there are about 13 million new cases of HPV every year, and over their lifetime, probably 75 to 80% of all sexually active people will have at least one or more HPV infections. And of course, high-risk types of HPV are what are linked with most cases of cervical cancer. So you see you see the incidence numbers that they're very clear, and this is really why it's so important that for the last century or so that we've been doing the work that we do. And it's especially important to think about this in terms of how it impacts women. And it was mentioned earlier that often there aren't obvious symptoms of STIs, and that's the thing. There really isn't always an early warning about it. A lot of STIs, especially in women, are asymptomatic, or symptoms may take a while to develop. When they do occur, they can be pretty nonspecific. They may mimic other conditions, so it's not always clear what's happening. And that's why we really hit the angle of testing so hard, because you just don't know based on symptoms. And untreated, there are a lot of adverse health outcomes. Chlamydia and gonorrhea can move from the lower genital tract, the upper tract, and cause pelvic inflammatory disease, which has a number of potential adverse reproductive health outcomes. It can also cause chronic pelvic pain. Then there's also the issue of a neonatal transmission. And this slide doesn't even capture trick, which we talked about there in the last slide. And what can happen there is you see a lot of outcomes such as premature delivery or low birth weight. So another thing that we talk about is disparities, especially among young people. Over half of all STI cases are in young people under the age of 25. And there are a lot of reasons for this. It has to do with social factors, but also young people tend to be more biologically susceptible to STIs. So a lot of our messaging and our communication around this has to do with populations that are most at risk and most impacted. You also see a lot of racial and ethnic disparities too. And it's important that we talk about this data and that we develop resources for these communities. But it's equally important that we do so in a way that doesn't add any shame or stigma to it. We need to talk about, well, why are these rates so much higher? It's not a matter of a lack of personal responsibility or individual behavior. It really has to do with social factors and social structures that drive these inequities. Poverty is a big factor there. The chaos that mass incarceration brings about in these communities. So it's important that we really explain why these are happening in a way that really serves the needs of these communities and really furthers the discussion, but does it in a way that empowers rather than brings extra shame or stigma to it. There are published screening guidelines, and we spend a lot of our time working on trying to translate the science for the lay public so that they really understand what they need to do. With chlamydia and gonorrhea, for example, that blurb is a little unclear as it's written, but the basic message is that all sexually active young women under the age of 25 should be screened annually for gonorrhea and chlamydia, and older women may need screening too, depending on their risk factors, like if they have new or old or new or multiple partners. So what we do here is we don't just like to throw out the nugget of you need to have this test, go get it. We'll also talk about things like, well, this is why you need to have the test. And do you have a place to go? Well, here's a link that'll help you that'll help you get the care that you need. And also being mindful, a lot of people don't have insurance. So we'll include resources for people that offer low cost testing or even free testing, things like that. Another barrier too is that a lot of times even people have a medical home, they have places to go. They may feel very awkward about it. They don't know how to have these conversations. They don't even know how to start. So along with giving people the nugget of information around, here's the tests that are recommended, here's a place you can go, here's also how to talk about it, here's a guide on how to really bring it up with your healthcare provider, how to have sexual health discussions, and really give some sample icebreakers and things like that. With cervical cancer screening, we've got some pretty clear guidelines, but it's not as simple as it used to be, because the venerable annual PAP is pretty much no more. You may still be screened with a PAP, but you're probably having it every 3 years rather than every year. And depending on your age, it may involve an HPV test, either alone or in combination as a co-test with the PAP. So the message here is we keep it as simple as we can. Pap screening starting at age 21. If you're a little bit older, then you may have an HPV test brought into the mix for you. Along with that, we'll also include links to a resource we have called Understanding Cervical Cancer Prevention. And what that does is it really is designed to help patients understand what these screening tests are like, what to expect with them. And then a little background on HPV and its role in causing cervical cancer and why there's an HPV test and what it means if you're positive for HPV, that kind of thing. We also have a track that if somebody has a positive or an abnormal screening test, they need to go for follow-up. What might that involve? If there's a colposcopy or a biopsy, what does that kind of thing mean? So that people understand what it is they're about to experience. And here too, we also have a guide about this. This is how you discuss it with your healthcare provider. Here's some sample questions you might want to ask, and just managing those expectations about this is what's likely to happen, and this is what you can expect. With pregnancy, screening during pregnancy is much the same message. Here's what's recommended. We encourage you to talk with your provider about what's indicated for you, and here's a resource to help you do that. So you just feel more empowered. It's really about managing expectations and empowering patients as they go, so that they just know what's happening. They really feel like they're part of the process and not just sort of a passive participant. This is an emerging area of opt-out screening around chlamydia and gonorrhea. And so under this model, what would happen is rather than opting in, it would just be a universal chlamydia and gonorrhea testing would happen appropriately for all young women, and they would be informed about it, and then they could opt out, if they choose, but they would have to actually opt out. It's kind of like if you're old enough to remember the old Columbia House record model. Do you remember that? And, you pay $1 and you get 10 records or CDs, and then the next couple of years you got to buy so many records. And they would send you a card every month or so, and if you didn't send it back to proactively tell them you didn't want it, you would end up with a record. And that's how I ended up with a record collection that had everything from Donna Summer to Led Zeppelin, I think, because I never sent it back. Well, this is a positive spin on that. I don't know that I have much of a communication nugget for you around this piece. And I'd be curious what any of you might think about it, but this is something that we're aware of. It's emerging, it's going to get more traction. And so we're already thinking about what we may have to do here from a communication standpoint, not only for patients, but there would be some provider messaging as well. So I'd love to know what you think about it. Here you see a summary of a few of the resources that we offer. We have a fact sheet called 10 Things to Ask Your Provider About Sexual Health and STIs. And it's designed to do some of the things I talked about earlier, something a person could even just print out and have in a very convenient, like a pocket-sized guide that they could take with them to these clinic encounters to just sort of prep them and get them started so that the conversations seem to be a little easier to have. We've also utilized some social media influencers, people on YouTube, for example, who have just massive followings of young women in the target range, especially around chlamydia and gonorrhea testing that we'd like to reach. And they've been a big help in helping us reach out into networks other than those that we would normally reach on our own. And everything we do really gets back to normalizing the conversation around STI screening. To say our view is this should be just as normal as talking about your cholesterol screening or something like that. So there you see my contact information. Everything I've talked about is either on our website or it is linked directly off of it. So please feel free to take a look there. And if you have any questions about anything that you see, just let me know. Thank you.
Thank you. Thank you, Fred. We really appreciate the setting the tone there for us for today's event. Please note to those that are tuning in live that you can submit questions at any time using the Q&A box at the bottom of your screen, and we'll try to address as many as we can during the panel discussion portion of the event. Next, we'll have Dr. Claire Bristow discuss more about our STI screening guidelines and the various diagnostics tests for infectious diseases.
Great, thank you so much for the introduction. I receive all of my current research support from the National Institutes of Health, and I have used donated testing supplies from Cepheid for research. CDC has recommended nucleic acid amplification tests, or NATs, which are tests that amplify and detect genetic material from the organism for detection of chlamydia and gonorrhea infection. Those NAT assays can be used with various specimen types, which include extragenital specimens. Among women, 14 to 44% of chlamydia and gonorrhea infections may be missed without extragenital screening. This may warrant screening at extragenital sites in addition to vaginal screening for some women. Most extragenital infections are asymptomatic and so are not detected in the absence of screening. NATs are commercially available from Abbott Laboratories, BD Biosciences, Hologic, Roche Diagnostics, and others. This is a picture of many of the different kinds of commercially available laboratory-based NATs. They're very large, they're very expensive, but they're very efficient. They can test up to 100 or more samples at the same time. And NATs are typically performed in centralized laboratories and out of reach for low resource settings and low and middle income countries potentially. And moreover, the turnaround time for test results, so from specimen collection to the results of most NATs can take 2 to 4 days and sometimes longer depending on the setting, which requires patients to return for treatment on a subsequent clinic visit, which can lead to significant loss to follow-up. And because of these challenges, there's been a call for making diagnostics available at the point of care or even at home. This slide includes a table from a recent paper and shows the current landscape of point of care tests for STIs. All of these assays represented here show high sensitivity and high specificity, so high performing assays that require less instrumentation or smaller instrumentation compared to the laboratory-based assays that I showed on the previous slide. The first column here, you see the Cepheid Gene Expert platform, which is an example of a commercial NAT that can bring testing closer to patients because it's much smaller instrumentation, but it's still limited by the need for expensive instrumentation and currently takes 90 minutes to perform. However, new, faster assays for that instrument are currently in clinical trials. The third column here is a recently FDA cleared handheld disposable NAT. So that doesn't require additional instrumentation, and that's from Visby Medical. There's a scarcity of successful demonstration and use of these such diagnostics, particularly in the US. And in order to implement a diagnostic assay outside of a centralized laboratory, the infrastructure must be in place to support its use. For example, some challenges may include the logistics around payers and billing for this type of testing, staff for running these tests in a clinical setting rather than in a laboratory or even in a non-clinical setting, and bridging the different sides between developers of these tests, researchers, and providers would be helpful to accelerate not only the development and evaluation of these types of tests, but also facilitate their uptake and wide-scale use in point-of-care settings. Another alternative to traditional diagnostic models would be the use of home-based tests or home-based sample collection. So these models may lead to benefits that may include increased testing, increased convenience, and additional privacy. However, there are also obstacles with these methods, including potentially a high price, or as well as the need for regulatory approval and regulatory oversight. And there's logistical and technical challenges to adoption of these methods as well. And then always sort of remaining is the potential uncertainty regarding whether these types of models may lead or may get to the sort of target populations with the greatest need. So I also wanted to touch a little bit on laboratory diagnosis of syphilis, another important sexually transmitted infection. In patients who have a current syphilitic lesion who seek healthcare, early diagnosis can be made based on dark field microscopy. However, most patients have no signs or symptoms of syphilis, and therefore in clinical settings, serologic tests are typically used. There are two classifications of serological tests for syphilis that are often used together to make a diagnosis, and those are non-treponemal tests and treponemal tests. Non-treponemal tests determine the activity of infection, while treponemal tests detect current or past infections, but can't distinguish between the two. Additionally, non-treponemal tests can revert to negative following successful treatment. Treponemal antibodies can persist lifelong following adequate curative treatment, making treponemal tests potentially less useful in high prevalent settings. However, they may be useful as a screening test. This image here is of the Syphilis Health Check, which is an FDA cleared rapid test for treponemal antibody detection. There are other tests at various stages of development and evaluation that include indication for a non-treponemal test result as well. And there are several advantages to these rapid point of care tests that could include a rapid time to result, a low cost compared to laboratory-based testing. There's minimal equipment needed, minimal training needed, and these can be used in non-clinical settings. But again, there are challenges around health system adoption of these types of tests. The World Health Organization established the global STI strategy, which is aimed at ending the STI epidemic as a major public health threat by 2030. And last year in the US, we had the first ever national strategic plan for STIs. And the National Academies of Sciences, Engineering, and Medicine was commissioned to convene a committee to examine the prevention and control of sexually transmitted infections in the United States and provide recommendations for action. So all of these are steps in the right direction for impacting public health around sexually transmitted infections, but gaps still remain in the technology, the evaluation, and the uptake of diagnostic strategies that may impact public health. So there's still a lot of work to be done. So thank you very much. And here again is my contact information as well.
Thank you, Dr. Bristow. Finally, I'd like to welcome Dr. June Gibson to present on screening and disease disparities in reaching vulnerable populations of women. Thank you, Dr. Gibson.
Thank you, Irene. So we're going to look at strategies to address disparities in women's health. I have no potential conflicts of interest in relation to this presentation. So the objectives is really to discuss STD screenings and disease disparities in women across a lifetime, and to provide some examples of strategies that we can use to actually reach women in underserved communities. So STDs are a hidden epidemic of great health and economic consequences in the United States. They are hidden from the public view because many Americans are reluctant to address sexual health in a way because of their biological and social factors associated with diseases. In addition, the scope and impact and consequences of STDs are unrecognized by the public and healthcare professionals. Now, this was actually the Hidden Epidemic, which was written in 1997. And 25 years later, we're still in the same place. And though they did not per se say women about the biological and social factors, but we know that women are actually impacted more. From getting diagnosed to dealing with long-term effects of sexually transmitted diseases, women not only face the disparity in infection, but they also face more severe health consequences. And as Fred stated, we're talking about PDI, chronic pain, infertility, ectopic pregnancies, and even a more likelihood to acquire HIV infection. Now, there are multiple factors that actually play into this. And so we have the individual factor, and this is going to be basically the biological things. You know, women are going to be more susceptible, in particular youth. And then we have interpersonal things, and this works with the social networks that we have. So you have partners within the social network, and then there's a mixing of partners, and there may be a high prevalence of STIs within that social network. And then we have the institutional, community, and structural factors, and these really overlap one another. This is when we look at the socioeconomic factors. We look at societal rules, societal issues and values, and we look at laws and policies. And you really see this factor playing out when there's closing of clinics, when the health department doesn't provide the service and there's no access to obtain STD testing. And you also find it when there's programs who do not consider how the societal factors impact women and how those factors may prevent her from actually obtaining STD screenings. And there are also social determinants of health that bleed into that. And we have stigma, discrimination, racism, poverty, transportation issues, safe housing, access to healthcare and education. And while all of these are really important, I'm really going to look at stigma and how it actually impacts a person from getting screened and actually taking care of themselves. Underserved, vulnerable, and marginalized groups can experience much higher levels of stigma because of a layered stigma effect. So stigma refers to how the individual fears of how they're going to be perceived in the community, what they're going to be subjected to, discrimination. But shame, which is really the thing that shakes everything up, shame is how that person feels about themselves and how they internalize the societal ideas about women and what women do and how women perpetuate things. And it creates a negative self-opinion among women. And we've seen this throughout history, throughout time, because basically STIs are inherently sexist. You know, there's stereotypes when it comes to men and women. If a woman has an STD, there's a level of promiscuity that comes to play. And particularly if you are a minority, if you're an African-American woman with an STD, this is something that's been taken across the board, where a man may perceive as, you know, rite of passage, or he may have this, you know, he was messing with the wrong woman, you know, that he shouldn't have been with her anyway. And this history of blame goes far back, even back into when syphilis first became a part of our society, where there was this notion that if they round up all the women with syphilis, that some kind of way would prevent syphilis from happening. But there was no indicators, no idea about how men actually fit into STDs and how they're actually perpetuating STDs among women. And then we have intimate partner violence, and this includes physical abuse, mental abuse, sexual abuse, and there are relationships where all three of these things actually happen. And that is the one of the greatest indicators of power dynamics, where you may be forced into a sexual relationship. You know, we have trafficking, and though anyone can be trafficked, women are going to be most likely trafficked the most. So how do you obtain screenings? How do you take care of yourself when you are in a very imbalanced power dynamics? And it perpetuates and continues. In fact, that 2-time women who are being abused are actually are at a 2.5 higher risk to get an STD compared to women who are not in a domestic violent relationship. And then we have unconscious bias, and though this can be throughout with any person, in particular with clinicians. You know, clinicians who are gynecologists, OBs, you know, primary healthcare, there may be a level of embarrassment or discomfort about talking about sexual health. And even if you have the tools to talk about it, if they begin their statement with, you don't need an STD test, right? So not only have they asked you a question, but they actually answered the question for you. And that can create just that shame comes back. And this makes this person, and she can feel like, well, my doctor thinks I shouldn't be doing this. My doctor's he's going to be mad at me. He's not going to want to treat me anymore. And this, how doctors don't handle their comfort and their level of embarrassment, that goes into a lot of the training that they don't receive and how they don't have an opportunity to really understand STDs and how they work and how women are often impacted. But there's some things that we can do. Of course, disease intervention specialists, but I ask any health department that's, this is a function of the health department in most states, but partner with community-based organizations. If we're currently doing the STI testing, then we are already in that patient's life. That patient trusts us. So having a better relationship with the community-based organization so the patient doesn't feel like they're pretty much being just tossed around. And this leads into treating their partners. Now, I do believe that's easier said than done, because we do have domestic violence. And if you're in a community and you're in a relationship where this is an ongoing thing, it's kind of hard to take home medication to your rapist or your captive to tell them, I need you to take some medication. But we can improve marketing. And I love what Fred had to say, marketing is going to be key. It educates women, but also educating clinicians on what's happening, ensuring that we get chlamydia screenings and that they're not embarrassed to ask the patient, and improving linkages to societal issues. When you don't know what she's going through and you don't know how it's impacting her mental health, because she's living in a patriarchal society where she's being portrayed as a vessel of STDs. And this can be very stressful for women. And so when you have programs, they should be linked to other levels of care, not just one aspect of it. They deserve it all. And expanding access. And this is through telemedicine and at-home testing. And if you haven't gone to WISP or STIC, with their websites, there are telemedicine sites you can go to where you can obtain the medication that you need, that they're sending screenings to your home. And this helps women because, again, we have busy schedules, have things going on, but this creates more of a safe place for us to obtain STD screenings. And we have a program at our clinic that's called Becoming a Healthier You. And the BHU provides patients with a snapshot of their preventive healthcare and their chronic healthcare. And what we do blood pressure, glucose, cholesterol, BMI, HIV, syphilis, gonorrhea, chlamydia, Hep C, Hep B. We do screenings for substance abuse, mental health, and high-risk sexual behaviors. And this is an opt-out program. Basically, if you qualify for everything, we're going to give you everything. And we've kind of removed some of the stigma that goes along with STD testing. Because mind you, you're getting a whole package. And in the communities that we live in particularly minority communities, we need all of it. We have to have the whole picture for that person. And with this opt-out package, we're able to link them to PrEP and behavioral health care, and STD treatment, reproductive health. And I have a quick video that I want to show you on how the mobile actually works.
Welcome to Open Arms Healthcare Mobile Unit, where we create a culture of wellness. Come on in so I can show you around. This here is registration, where all intake happens. The waiting area is the bathroom, where all your swabs and things may take place. Here we have the triage area, as well as lab. This is your one-stop healthcare shop. Nice to meet you all this morning. I'm Gerald Gibson. We got to do like the COVID protocol. And what we're doing here today is called Becoming a Healthier You. We check your BMI, check your blood pressure, we check your glucose. And also, if you're sexually active, we'll do a rapid HIV test where you get your results right now. Syphilis, gonorrhea, and chlamydia. So we try to give people like a whole view of their overall health.
I was impressed with all the different services that they offered and how much they seem to be able to do in the tool van.
We look at Mississippi, we are still number 1, number 2, and number 3 in HIV case rates. Syphilis, community gonorrhea, and you know your status, you're able to protect yourself better.
So many people don't have health care at all. Having it just be straight up free makes it easier for everyone to get tested.
And any services that they need within these services, they can come to our main clinic, which is at 805 East River Place. We also have a sliding fee scale. So we give them every option to access their health care. These are actually other services that we have: mental health, telehealth, food pantry. A lot of people don't think that healthcare is their right, and a lot of people really do not think about their sexual health and how it can have long-lasting effect on their lives. It's about access, awareness, and information. Voting in itself is going to be something that some communities have never seen before. Like, when we bring healthcare to you, all you gotta do is access. And we go anywhere in the state of Mississippi. Lately, we've been doing a lot of major vaccination events, and the incentive has helped. Incentives are a $50 piece of gift card to get your first and your second dose. Here we go, stick. You have to access all of your resources, all of your mechanisms to get people to access care sometimes. When it comes to community health, it takes a village. You have to give a little bit of yourself in order to connect. Being loving, being caring, being empathetic and sympathetic. What we want to do here at Open Arms, we want to make sure that your health care is right, but all of your health care, we're talking about the holistic person. We need to touch you from A to Z in order to make you whole.
So that's our Becoming a Healthier You program, and we do it on the mobile. We also do it in the clinic. But in COVID, we found some new ways. You know, COVID brought about a lot of telehealth. So we do telehealth in multiple ways, including primary health care, behavioral health care, family planning. But we merged that BHU into a full telehealth process. So we actually can send your labs to your home. So that eliminates you having to come to us. It creates just a different atmosphere and more availability and accessibility for women. So we're able to do the full BHU, including the glucose, the cholesterol, and this includes, you know, all of the gonorrhea and chlamydia. And we also can include pregnancy tests. And we do it for initial prep, and we also do it for our follow-up prep programs. Also, that is you know, ways that we can actually just change how women are actually being impacted in this world. And thank you.
Well, thank you very much, June. And so I invite our panel to now turn on their cameras. And again, for those who are tuning in live, we ask that you submit any questions you have using the Q&A box at the bottom of your screen. We'll try to address as many individual questions and common things as we can during the discussion. And so something that's been touched upon, and actually we can start off with this question that I saw that was submitted earlier. Fred, you mentioned that young people are biologically more susceptible to STIs. Can you elaborate on why that is?
Sure. And I'm no clinician to be sure, but my understanding is that the immature body as it develops, like especially with young women, the developing cervix is just simply it's more susceptible. It's just not fully developed, fully formed, and it's just easier for those pathogens to take root there.
Thank you. And so the June, you talked about the mobile, and Claire, you even mentioned the home testing and some of these other options. How common is it to actually do some of the self-testing, and how accessible are these materials?
Well, for us, it's very accessible. Any patient can do telehealth. Any patient can have the labs mailed. It creates just a new level of access. So yeah, very, very accessible.
I think in some settings, it's obviously more available than others. One of the challenges that I think a lot of health systems face is that the sort of logistics around who's going to pay for those services, and can, for insured patients, how to bill for those services. I think there's a lot of areas around that still need to be addressed and figured out within specific health systems and for specific payers. For patients who are willing to pay out of pocket for some of those screening tests, they are available from sort of commercial laboratories, or you can order a test to your home, or a collection kit to your home, and those sorts of things. But I think there's a lot of issues about about cost, and that may make it more difficult for some people to access those tests.
And for us, we have a great partnerships. You have to have partnerships to be able to get this done. We have partnerships with the health department. We have family planning grants, which is going to pay for the clinician and pay for part of that service. But you use your resources to be able to make it happen. And it can happen. I mean, if you can do it in Mississippi, I'm going to say you can do it anywhere. I mean, mind you, you know how our healthcare system is here, but it is quite doable with the right partners.
And to that extent, as it's been echoed throughout so far, having those partnerships, and then that also helps to build awareness and get into reaching populations and communities that are broader. And so that really does work, because I think there's that trust piece to the healthcare system that we all know is very important. But interestingly enough, Claire, when you talked about the NAT tests, and I feel like, and even the PCR test, that 2 years ago, that might have been a very foreign concept for a lot of people. Do you find that now, post like having dealt with a lot of COVID testing and everything, that it's helping? And I guess even, Fred, June, to chime in, has it been helping in any way, understanding STI testing, understanding these innovations, these diagnostic tests, and people's willingness to do them?
I think from a patient perspective, patients are much more informed about what diagnostic testing needs to look like for all kinds of infections. I think, again, I sort of go back to this cost perspective. For COVID testing, public health departments are paying for those tests, and the resources have not been as well allocated for STI screening. And so I think, especially for home-based collection methods, they're just not as available in a lot of settings.
COVID was a change for us. We've had similar programs for years, but once COVID became a part of our world and everything went to telemedicine and telehealth, it became much easier for us to be able to get patients to utilize the service. And so now that they're a part of it, they don't expect anything different. They want the services to continue the way that they are.
Yeah, and I think systems are still strained from the pandemic, and there's still just so much fallout and a lot of catch up. We see we're getting a lot of inquiries from women who maybe haven't had their normal exams over the last couple of years. Now there's a lot of them, and there's a lot of questions that are coming up that they haven't thought about in a while. It's almost like getting used to a new normal.
And I know there is a heavier burden on disease symptoms, outcomes, particularly among women, that it's, shouldered. I know early on, for example, in HPV testing, you always had the pap smear, and it was that burden is kind of rested on women more often. And so, but what can we do to ensure that male partners are routinely tested? How is that communication being done to ensure women's health through making sure male partners are also getting the necessary screening and prevention?
Well, one thing that we do, especially in the HPV realm, is we actually have some things called a man's guide to HPV, where we try to break everything down about what men need to know, but also why it is that some tests that are available for women aren't available for men, and just why that is. But here's what you need to know. Here's what you can do more proactively. So that's one thing. The other thing is too, we also develop some resources for a partner who's in a relationship with someone who's diagnosed with HPV, who has an HPV-related disease, how to support them, how to understand what they're going through. So we try to reach out to guys, not only as patients, but also as partners of somebody who may be dealing with cervical cancer or an HPV-associated disease.
And for us, we market the BHU as a every 3 month package to come in and get screening to men and women. So the entire community gets the exact same package. So it includes, and mind you, the clinic actually has a equal balance of men and women, and majority of those people came into the clinic through the BHU.
And one thing I'd like to add is we also developed a resource for men of transgender experience, what they need to know about HPV and screening tests. That's definitely an emerging area for us, and one that we think is just going to be increasingly important.
So we've gotten, a bit of, I guess, chatter or questions throughout in our Q&A about herpes testing, and that it doesn't seem to be as much of a priority, or the involvement or even the specificity is low. Can we kind of talk about a bit there? It's why it's not on the priority when it comes to testing. I know we always hear about chlamydia, gonorrhea, syphilis, but it has a relatively, and on the diagnostic side, and it has a relatively high incidence in women compared to the others as well. I mean, not chlamydia, but gonorrhea and the equivalent. So why do you think that is? And how can we improve or lift the priority for herpes and the attention to diagnosing and treating that?
I think one of the reasons it may not have as high priority is that most cases are asymptomatic. Probably 80–85% of those with genital herpes never know they have it. So I think that's part of it. If most of those people were having symptoms, then you may see a different dynamic around it. And then we also don't have consensus guidelines really pushing herpes testing the way it's like we have something very clear for chlamydia and gonorrhea and sexually active young women. It's like, here you go. Here's what you need to do. Here's the test you need to have, that kind of thing. You could certainly make the case. So, I mean, we've had a herpes resource center since the late 70s. We even had a herpes hotline at one time. I was privileged to be able to work on. So you don't have to really work hard to convince me that we need to do a better job in herpes.
Herpes is more of an in-clinic process for us. The mobile, the BHU is more of a community piece. So that's what we can take statewide to provide to everyone. But herpes, we do testing for it, screenings for it, but it's going to be more of a, again, because it's asymptomatic, it's going to be more of a in-office process versus doing it on the mobile.
Yeah, I see some comments that, the fact that it is asymptomatic and it has longer term impacts when it's untreated being an issue. And of course, because it's asymptomatic, it's low priority, it's not getting treated, that that's definitely a call to action that we need to improve in that space. Maybe Claire, can you touch on like the serological tests and the effectiveness of that, or where there is need for innovation that you see coming down the pike for herpes or for other STI tests?
Yeah, so I don't know much about the specific assays for herpes, but I think part of the reason why diagnosis isn't, or diagnostic testing isn't performed, is because of sort of mirroring what Fred just said, that CDC doesn't have screening recommendations for herpes the same way that it does for the bacterial STIs that I mentioned. So it's more of a provider case-by-case basis. The other thing is that herpes is not a reportable or notifiable disease. So it's not mandated by law to be notified, to notify the health department about a case of herpes. And so the sort of surveillance data is more limited as well.
I'm trying to, let's see how we can formulate this question. So during the pandemic, the CDC data suggests that STI cases increased, especially in the first year. And we talk about some of the diagnostics. And I know, of course, to do full prevention and care deals with behavioral change as well. Are there opportunities? how can we maximize those opportunities? Like, are we taking them in the healthcare setting to say you're not just getting tested, but you're also getting education? Like, what does that look like to help inform behavioral change? So we don't have to quote unquote diagnose as much, right? That we're also getting some of that change on the front end, so that then when they come in and they're getting their testing and their screening, it's a more effective healthcare loop.
Well, I talked a little bit about that. Our approach has always been to, like I said, trying to manage expectations, to let people know what to expect with the test. I mean, we still get a lot of people who calls up and or email us, and we still get calls and emails, and actually snail mail too, for people, and they'll ask us things like pretty commonly, is it going to hurt? What's going to happen? They don't really know what to expect. So letting people know, these are the tests, and this is what to expect in your clinical encounter. And again, here are some questions to ask. Here's some ways to prepare yourself for it. I think that goes a long way to making these things. I'm not going to say it makes them easy, but I think it does. It smooths the process out of that.
And one of the topics I wanted to circle back through, I know Fred, you'd mentioned a bit about pregnancy and the implications of testing. If you want to elaborate, what should women know about STIs in pregnancy? We know that there can be some neonatal transfer that can affect, especially during delivery. But what about the testing windows as far as being screened? What's safe? How, is it something that should be automatic? Should a woman be asking when she's pregnant just to be tested in general? What recommendations do you have there?
Yeah, and that gets back to the point of I had several STIs listed on the slide about this is what's typically tested for early in pregnancy, and this is great, but have a conversation with the provider about, given your sexual history, given your situation, this may not be a comprehensive list. So again, it's about having the conversations and really, tailoring the care to the patient, I think is one thing. And just quickly on herpes, we get a lot of questions around herpes in pregnancy. Both from women who have herpes, and as well as women who don't have herpes, but their partner does. Should we just abstain from sex during pregnancy? Is it safe? What can we do? So we spend a lot of time. In fact, I'd say most of the questions we get about pregnancy actually do relate to herpes. We get more herpes questions than really just about anything else, herpes and HPV. And so developing those kinds of resources and explaining how herpes works in pregnancy, and that if a woman has a herpes infection, a long-standing herpes infection, there's probably not a great chance of neonatal transmission. But if she acquires it during pregnancy, especially during the later trimesters, that can be that's really where the main risk comes in. So thinking about what that means, managing within your relationship, and giving the education, again, just the way to actually interact effectively with the healthcare provider to manage all these things. Some of that's just simply knowing how to model these conversations. This is what you can ask.
And I wanted to, Claire, if you can kind of elaborate, or just, I guess, maybe discuss, you talked about extragenital screening, and while it's kind of a long word and it's outside of genital, what is that? Can you describe it a bit more in layman's terms? Like where is it tested? What do you test when you do extragenital screening that's different from the genital STI screening?
Yeah, so for chlamydia and gonorrhea, sort of more specifically, we need to test using a specimen from the anatomic site of infection. So that's different than maybe for syphilis testing, where we're doing a blood test. And so for chlamydia and gonorrhea, those infections are also common in the throat and rectum. And so a throat swab and a rectal swab can be used for screening for those extragenital, so outside of genitals. And there is additional cost associated with that, because extragenital testing means you're performing 3 different tests, one for each anatomic site. Mm-hmm. So 3 when you include genital testing as well. And so there's additional cost that comes with that. And so one of the things that I'm really interested in is finding a way to reduce the cost by perhaps performing 3 tests or one test with 3 anatomic specimens. So combining those specimens into one test. So that's something that I've been sort of exploring in our setting here in San Diego, and we've implemented. However, when you get a result like that, then you don't necessarily know which anatomic site is infected, which may not be a problem in terms of treatment, because treatment would be the same regardless of anatomic site, but patients may want to know which anatomic site is the site of infection. Also, if we're trying to do a test of cure, so a test following treatment to ensure that the infection has been cured, we may want to know which site that is as well for that reason. And so for those infections specifically, we're interested in thinking about those extragenital specimens.
Thanks so much. And so as our time is coming, we're wrapping up. I have one last question. We often have patients and healthcare providers, as well as researchers and policy professionals that tune in to our webinars and public forums like this. What is one takeaway that each of you would recommend to viewers to help them support screening towards the prevention and spread of STIs? And so if we start with Fred, then Claire, and we'll end with you, June.
Sure. I'd say rely on the science, rely on the guidelines, but understand that all of this is sometimes as much an art as it is a science, and that it needs to be tailored to the individual. And just because something isn't covered by the guidelines or there aren't clear recommendations doesn't mean that the patient in front of you doesn't need that kind of screening or that kind of testing.
And I think one of the things that I would give as sort of a takeaway is thinking about how we can implement more innovative screening, more immediate screening, or improved screening in different settings.
Well, I would suggest, let's normalize the conversations that we have around STDs and reproductive health. It shouldn't be seen as this faux pas, something that can't be discussed. And I think the more we talk about it, we'll be able to prevent more things because everyone becomes more educated at that point.
Thank you. I think that between the three of you, that really wraps it up really well. Normalizing, educating, and innovating. And so we want to thank you very much. Put a special thanks to our amazing panel for all of your time and your insight, and to Roche for their support of this public forum and the SWHR Value of Diagnostics Within Women's Health series. We're looking forward to highlighting some more areas of women's health that benefit from innovations in screening and diagnostics. Our next event will be in May for Osteoporosis Awareness Month, when SWHR will focus on assessing and promoting bone health across the lifespan. We invite you to connect with us on social media and visit our website, www.swhr.org, to register for future events, download women's health resources, and sign up for our newsletter. We'll send out an email with a recording of today's webinar to all registrants, as well as post the recording of today's event on our webpage, on the event webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue the conversation with hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Sexual Health. Thank you for joining us.